Thanks, Somil. Since some of the speakers have bunked, they've not come, and one of the presenters has got COVID, so now I have to fill in. So this was a very interesting case. This was a lady well known to my wife's gynecologist. So the gynaec calls up and says, I have a patient for you. I said, I'm not going to do a delivery. She said, no, something has fallen on her eye and she's coming from Goa. So she was actually lying in a hotel by the pool and a mango fell on her eye. That's why I named this video Mango Season. So what do all patients do? They go to the GP, give them Ciplox. So 3-4 days she put Ciplox, then she realized now she can't see much. So when she presented, the IOP was 50 with a clear cornea, mid-dilated pupil, and the lens was luxating into the anterior chamber. Naturally, the angle was narrow, and that's why IOP was up. So give us some mannitol, oral Diamox, and we started on it. Cut the audio, huh? No audio. That's why it's called Mango Season, people are wondering why. So this whole lens is sitting now basically in the AC with uniformly subluxated zonules all around. So you do a nice small about 5 millimeter excess with the sharpest capsular excess forceps that you have. So we don't want to tear the rest of the zonules also. Once it's done, and this was a youngish person in their 30s. I don't like to say middle-aged anymore because we are all middle-aged. So in this case, I decided to support the bag. Now, when you open a packet of capsule hooks, you always wonder why they're given 5 hooks, because you only use 4 to open the pupil. So what is the 5th one for? In case you drop one, there's one extra. No, actually, you're supposed to use 5 to support the bag like this. So you can support a capsular bag, which is lax, very efficiently with 5 hooks. So that's what the 5 hooks are for. So you suck out all the cortex and a little bit of an excuse of a nucleus there, and then do a nice eye. Remember not to pull the bag off. So if you go slowly, you can manage this very nicely. So basically, why am I showing you this video? Because in every case, you don't need a Mehta segment and you don't need to suture it. Putting a large capsular tension ring sometimes will do the job and generate enough tension in the capsular bag. And this video is about 5 years old. And this person comes every 6 months and shows, and everything looks good. I have no doubt one day that bag might subluxate, but that day isn't today. So in goes the capsular tension ring. So I love these off-tech preloaded rings. They make all other rings look agricultural. So these are very nice and easy and idiot-proof. You just put it in the bag, inject it, it goes and sits there. And in goes the IOL. And IOL also sitting nicely in the bag. Nice single-piece lens. And you can see the rhexis margin is overlapping it, and that's the end of the surgery. Let's have a look at the next one. This we already showed. So this was a very nice and interesting case. Patient comes to me with a nice hazy cornea. When you look inside, there's a PC IOL in the AC in a vitrectomized eye. So what has happened? Somebody did a cataract surgery, dropped 1-2 fragments inside, did some kind of 3 PPV with all sketchy history, no proper notes, and left the PC IOL 3-piece lens, a foldable lens, 3-piece lens in the AC. So when a PC is in the AC, it obviously is going to lead to corneal decompensation. Otherwise, all of us would be putting a PC in the AC and nobody making all these videos. So DSEC can only work when we have an IOL behind. So now the vitrectomized eye, I'll take out the IOL. How will I put the air bubble there? It will just keep going behind and the graft will fall in. So first I had to flange an IOL and then do a DSEC. So let's see how this went. So make a nice big tunnel, about 6.5 mm. Remove that epithelium so we can see better, and out comes the PC IOL that was living in the AC for a nice long time. AC maintainer, 1.5 millimeters you mark on the marker. And now proceed to flange the lens. Flanging is very easy and it's a simple technique to learn. Just put in the 5 or 6-O-proline in that needle, go inside 1.5 millimeters behind, and just push the suture from behind. It comes out and then you pull it out. So this eliminates all this complicated maneuvering in the eye, which is really tough to do. That's the DSEC graft getting prepared. So you got the two sutures, one from one side, one from the other side. And that's your PMMA lens with the eyelet and the low temperature cautery that we use to flange it. And that whole assembly, you just push it into the eye now. That's the second one. That's the trailing haptic. Create a nice flange there. The bigger the better. We don't want it to slip off. And that's basically the end of it. Now in goes a sheets glide. We take that pre-prepared cornea and push it in with a Sinski. So remember, it's a vitrectomized eye. If we did this, otherwise the chances are the graft would fall inside the vitreous. If we didn't flange a lens, close all the openings. And this is the end of the case. Patient still comes and sees fairly well, about 612 or so. And this is the final thing I wanted to share with you all, which is pediatric cataract with persistent fetal vasculature. About 6 months back, I was referred this kid from the Middle East, a few months old. And all of us that did MS in the 90s, and we used to read Piemann and Jacobiak and all, this was called persistent hyperplastic primary vitreous. It's only after 1997 it was called persistent fetal vasculature. So this was a case of anterior PFV syndrome and a unilateral cataract. And why is a unilateral cataract important in this case? Because if you have a unilateral cataract in a baby, the incidence of anterior vitreoreticular interface dysgenesis is 90%. So you have to expect that something will be wrong with the posterior capsule. Yeah, and the plaque. So let's just see the quick video, which is 1 minute. Yeah, we have 5 minutes.
Yeah, we have 5 minutes.
Yeah. So that's the kid with the posterior capsular plaque. So they referred from Middle East with all the investigations, B-scan, this, that, and all. So naturally, I'm not a retina surgeon, but I also realized that once I do the cataract surgery, the globe will be soft and won't be able to get a port in. Use a micro-rhexis forceps and make a small rhexis through the side port. Otherwise, the chamber will keep shallowing in a child. Just do an eye and just see what happens now. And that's what we predicted, that the posterior face is going to be open. So there is a perfectly punched out opening corresponding to the posterior capsular plaque that we expect to be there in a case like this. In goes the IOL and tuck it into position. And the IOL will tamponade the rent behind. And now we go behind and we see what's going on with the vitrectomy. That's the B-scan the patient came with. And you can see the hyaloid artery behind. And you can see that in the video as well. So my vitreoretinal person did the vitrectomy. Remove the hyaloid artery, and the kid still has come about 6 months later and done a follow-up and follows light. It's very difficult to know how much the kid really sees, but I think the kid can see, and I visualized the fundus. We did EUA, everything is good, IOP is good. So I think the patient is doing well. So that's the end of the series of cases. That's the take-home message. And let's wind up now. Saumil, being a retina surgeon who does hundreds of cases a year, how many of these persistent hyaloid arteries and all do you see?
So not very common, obviously, but they have a reasonably good prognosis. They are all microphthalmic a little bit, but it's a very operable condition unless it's associated with a falciform fold. No one can hear. There are mic teacher. Unless it's associated with a falciform retinal fold or the patient has gone really amblyopic before it has been discovered, it has really, really good prognosis, and we should try out all these cases. That was an excellent demonstration of this. Yes, yes, Ashish.
Yes.
Ring
Yeah,
first.
I used to put the ring first and then it used to get stuck in the cortex and then the cortex wouldn't come out. So this case I decided I'll put 5 hooks and see how it goes. Because the lens was really not that unstable also. If the lens looked like it was going to descend in the vitreous, I would have definitely sutured it. But this was a case where it was just enough subluxation that a CTR would do the job. Yeah, I only use the hooks when I get a subluxated cataract. That's not that often.